Hello, everyone, and welcome to the Med ED page. This is Dr. Omar Awan, and I want to talk about high-yield imaging review for the peds shelf exam. And I think there's very few resources to help med students ace their shelf exams in medical school. So I want to do a very quick high-yield review of the most common imaging abnormalities that you're likely to see on the exam. If you haven't already, please subscribe to our channel, Med ED page. Please support our mission in sharing free knowledge throughout the world. So I'm going to show you 24 super high yield diagnoses and images. So here we go. So this is case one in chest and neck. Here we have a frontal view of the chest and a single view of the femur. And what we have is we have an endotracheal tube and an enteric catheter, but I want to point your attention to these ribs here. These ribs are fractured. So this is an acute fracture because we see the lucency along the posterior rib here. And here we have maybe a subacute to chronic fracture with some callus and new bone formation that's fusing a prior rib fracture. So we have fractures of ribs at different ages or different stages of healing. And the femur, we have a metaphyseal corner fracture. So this is a really important fracture. This is essentially pathognomonic for child abuse or non-accidental trauma, right? We almost never see metaphyseal corner fractures in anything other than non-accidental trauma. So this is a very high yield image for the shelf exam. You want to look for that discrepant history, right? Like the parents come in saying that they fell, but there's all these injuries that don't match the fall, right? So the next step would obviously be to notify Child Protective Services. So very high yield case of child abuse. Case two, we have an image, single frontal view of the heart. Notice that there's massive cardiomegaly. The heart looks almost box-shaped, right? This could be a pericardial effusion or something known as Epstein's anomaly, right? So this is a nice example of Epstein's anomaly where you get downward displacement of the septal and posterior leaflets of the tricuspid valve. Look for that huge heart, box-shaped heart, Epstein's anomaly. Case three, we have a CT image of the chest and lung windows, and we have a CT image in soft tissue windows of the upper abdomen. Notice that there is bronchial thickening here. The walls of the bronchi or the airways are thickened. This is bilateral. You can see it here in the left side as well. And on the CT scan, we have fatty atrophy of the pancreas. The pancreas should normally live here, and it should have the same density as the liver and the spleen, but instead it's very dark and replaced with fat. This dark area is what fat looks like on a CT. There's also hepatosplenomegaly. There's a nodular contour to the liver that suggests cirrhosis. So all these findings combined is suggestive of cystic fibrosis, okay? Cystic fibrosis typically involves the upper lobes. When it's an autosomal recessive disease, the question is likely to ask you something about the dysfunctional chloride ion transport. But those are classic imaging findings in cystic fibrosis. Case four, we have a single frontal view of the neck. Notice that we have the steeple sign here with narrowing of the airway. Okay, this is seen characteristically in viral croup. So this is a nice example of viral croup. This is viral inflammation of the airway, usually from a para-influenza type virus, 1 to 3, sometimes adenovirus. Typically, they present with a stridor or a barky cough. That's what they're going to show you in the question stem. The steeple sign is seen on X-ray. Mostly, this is done with supportive care, unless it's a little bit more serious where they require hospitalization. But usually, the vast majority of patients are okay with supportive care. This is what foreign body obstruction would look like. This is a coin that's dislodged in the airway here. This is what the coin looks like, this metallic radiopaque foreign body, in case you were to get a question on foreign body obstruction. Moving on to case five, we have opacity and consolidation within the right lower lobe. This is nothing other than a right lower lobe pneumonia. This is a very basic case, but quite frankly, the shelf tests basic cases. So when a patient has fever, leukocytosis, cough, right, presenting with this chest X-ray, where this is the right lung, this is the left lung, this is the heart. This is a nice example of what right lower lobe pneumonia looks like. Always be careful and be aware of very common entities covered on the shelf exam. Moving on to GI, we have a newborn here, right? This is actually GU actually, excuse me. We have an enteric catheter here that's ending in a blind-ended pouch here, right? It's not going into the stomach. It's kind of going and veering to the right of midline, right? But we do have gas in bowel loop. So this is a nice example of what esophageal atresia and tracheoesophageal fistula would look like, right? When you have, a feeding tube that can't be passed into the stomach, and it ends in a blind ending pouch here, in the proximal, upper chest. but you still have gas in the stomach and the bowel because of the tracheoesophageal fistula, right? So this is a nice example of what esophageal atresia and TEF would look like. You can't pass the feeding tube. It's stuck proximally in the dilated esophageal pouch. Usually there is air in the stomach and bowel, but there are different types of esophageal atresia and tracheoesophageal fistula. Remember always a Vector L association of like vertebral anomalies, anal anomalies, cardiothoracic problems, tracheoesophageal fistula, renal anomalies, and limb deformities, right? So that's a highly testable association with esophageal atresia, TEF. Moving on to case 7, we have a single frontal view of the abdomen. Notice the double bubble sign. This here is marked gaseous distension of the stomach. This is this air-filled distension of the duodenum. There's no gas distal to the duodenum. Double bubble sign that we see in duodenal atresia, right? So nice example of this. Usually this presents with bilious vomiting, commonly tested association with Down syndrome, right? If you know this, you'll probably know enough to answer the question on the shelf exam. This is an upper GI series opacifying parts of the bowel. So this is the stomach here. This is the proximal intestine here. This bright stuff is contrast in it. Notice this corkscrew appearance to the bowel here, particularly the small bowel, right? The duodenum here, right? This is characteristic of what volvulus would look like. This corkscrew appearance of twisting a bowel that results in ischemia and obstruction, right? The next step, if they were to ask, would be surgery, right? This is a surgical case, right? This has an increased incidence in cystic fibrosis, which you should know about for the shelf exam as well. Moving on to case number 9, we have a contrast enema, right? And we have contrast opacifying the rectum, the distal colon here. Notice that the rectum is, and the large bowel is dilated. There's a focal area of not narrowing at the rectosigmoid junction, and this rectosigmoid ratio is less than 1. So this is the rectum that is, the caliber, the diameter is much less than the diameter of the rectum here, right? Or excuse me, the sigmoid colon. The diameter of the rectum is less than the diameter of the sigmoid colon, and this area of narrowing here is what's indicative of Hirschsprung's disease, right? So the rectosigmoid junction is less than 1 in this case of Hirschsprung's disease. This is a case of distal bowel obstruction. This happens from an absence of ganglion cells in the myenteric and submucosal plexus, and the next step would be rectal biopsy. That's how this is diagnosed, and eventually these patients often require surgery. So this is a nice example of Hirschsprung's disease. This is case 10. We have CT images of the abdomen here. Notice here we have abdomen, and we have different densities here. The bowel is a soft tissue density, which we see here, but then there's darker density, which is fat, right, in between another loop of bowel. So this is actually a case of intussusception, where you get telescoping a bowel within one loop of bowel going into another loop of bowel. You can actually see it here on the coronal image. This is the telescoping of one loop of bowel going into another loop of bowel. When you have alternating areas of soft tissue and fat, kind of in a concentric ring-like orientation like you see here, that's indicative of intussusception. And you can actually on the coronal image see this brighter area of bowel loop going into this other area of bowel loop with the bowel wall here and the fat in the middle here. This is telescoping of one loop of bowel into another. Nice case of intussusception, right? You always want to do an air contrast enema as a next step. This is an example of what an air contrast enema would look like. Excuse me. And this is what you would do. Now, most intussusceptions are ileocolic, but sometimes you want to look for a lead point, like something like a Meckel's diverticulum, lymphoma, something like that. Moving on to the next case. This is case 11, a premature newborn with RDS. Notice that we have a lot of free air under the diaphragm. This is a patient with necrotizing enterocolitis, right? So it typically presents with free air under the diaphragm. You can have air outlining the wall of the bowel. That can also be seen in necrotizing enterocolitis, right? Typically, the risk factors are a premature infant, right? They have RDS or hyaline membrane disease. You're looking for free air under the diaphragm. The next step is always going to be to do surgery. Nice case of necrotizing enterocolitis. Case 12, we have dilated loops of bowel. So we have distension of pretty much all loops of bowel, the stomach, the small bowel, the large bowel. We do a contrast enema, and we see that there are, first of all, the left colon looks a little smaller in caliber, and we have all these filling defects, right, within the bowel, right? So this is a nice example of what Meconium ileus would look like, right? When you have filling, these Meconium pellets have filling defects with a small caliber left colon, right? So this is a nice example of what Meconium ileus would look like. It's intestinal obstruction of the terminal ileum from impacted meconium. Very high association with cystic fibrosis, right? 90% of patients with Meconium ileus have cystic fibrosis, so very testable material here. Moving on to case 13, patient has right lower quadrant pain. They get an ultrasound. We have this dilated tubular blind ending structure in the right lower quadrant, right, with a thickened wall. We have on transverse imaging, we have this, calcification here, appendiculus in the center with some shadowing. Nice look for what acute appendicitis would look like. We obviously do ultrasound in pediatric patients. We don't want to radiate them with a CT. So this is a nice example of what appendicitis would look like on an ultrasound. Okay. So the next step, if they ask you that, is going to be surgery, right? We're going to do surgery for acute appendicitis because we want to prevent perforation. Case 14, we have an ultrasound image in a newborn infant, right? We're looking at the pyloric channel here. This pyloric channel is elongated. The wall is thickened. It's more than 3 millimeters. The channel is more than 15 millimeters. Nice example of what pyloric stenosis looks like, right? 2 to 12-week infant with projectile non-bilious vomiting, thickened pyloric muscle leading to gastric outlet obstruction. The next step is going to be pyloromyotomy, right? Surgery, pyloromyotomy. Nice case of idiopathic hypertrophic pyloric stenosis. Now moving on to GU, we have a frontal view of an X-ray showing a mass, right? There's this mass effect on the colon that's pushing all the bowel loops to the left. So this suggests that there's a mass here in the abdomen. We do an ultrasound of the kidney. We see a heterogeneous mass arising from the kidney. This is what a Wilms tumor would look like, right? So most common kidney tumor between the ages of 2 and 4. The tested associations here would be Beckwith-Weidman syndrome, which usually has, macrosomia, enlarged infant, macroglossia, enlarged tongue, right? They can have umbilical hernia defects, the Wagner syndrome, right? Wilms tumor, aniridia, GU anomalies, intellectual disability. Those are all testable associations with Wilms tumor that have been seen on the shelf exam by many students. Okay, so nice example of what Wilms tumor could look like on X-ray or ultrasound. Moving on to MSK, we have this image here through the pelvis. Notice there's a lucent lesion arising from the epiphysis of the femoral head. It's radiolucent with some rings and arcs, high density material here, very well defined along the epiphysis. The key is it's a pediatric patient with epiphyseal lucent lesion. This is what a chondroblastoma would look like, right? It's a chondroid benign tumor in kids. Anytime you have an epiphyseal lucent lesion, you want to think of one of 4 things, right? A chondroblastoma, infection like subacute osteomyelitis, EG or eosinophilic granuloma, or a giant cell tumor if the growth plates have closed, maybe like an 18, 19, 20-year-old, right? But in an older person. But typically, this would be a nice look for chondroblastoma. In contrast to this case, which is an osteosarcoma, right? The most common osseous malignant tumor in a kid. You have replacement of the marrow. The marrow is typically nice and fatty and bright, like it is here in the tibia, but in the femur, you have dark signal, a lot of marrow edema, subperiosteal edema, lifting of the periosteum. Nice example of what osteosarcoma would look like. The most common primary malignant bone tumor in kids. The association with retinoblastoma is very testable on the shelf exam. So definitely want you guys to remember that fact, okay? Case 18, we have an AP view of the pelvis. Notice this lytic permeative destruction along the iliac bone, right? You can see the destruction here along the iliac bone here. This, in contrast, is what a Ewing sarcoma would look like, right? So this is another common pediatric malignant tumor that you should be aware about, most commonly from the ages of 5 to 15. In the long bone, it'll typically be along the diaphysis of the bone. An osteosarcoma would typically be in the metaphysis of a long bone, but a Ewing sarcoma is usually in the diaphysis of a long bone. This is an aggressive small round blue cell tumor. The permeative lytic destruction is the key to the diagnosis. Moving on to case 19, notice that we have beaking of the proximal medial tibial metaphyses. We can see this bilaterally. Nice example of what Blount's disease would look like, right? Beaking of the proximal tibial metaphyses. This is disordered enchondral ossification of the posterior medial proximal tibial metaphysis. Beaking is the key imaging finding. The testable association is with obesity. obesity is a risk factor for getting Blount's disease. Moving on to case 20, we have images of bilateral hands in a very young person. Notice the metaphyseal cupping and fraying here, the irregularity along the metaphysis of the radius, the ulna. It's a bilateral symmetric finding here. This is seen in rickets, right? Metaphyseal cupping and flaring is usually due to vitamin D deficiency. That's the testable fact that you'll likely be asked. The next step is obviously to give vitamin D, possibly calcium. But it's this metaphyseal cupping and fraying and irregularity of the metaphysis that suggests the diagnosis of rickets. Moving on to case 21, we have a lateral view of the elbow. There's a fracture here along the supracondylar humerus, right? There's an elbow effusion. You see all this, the effusion is manifested as this, dark triangle here. This is the posterior fat pad. This is the anterior fat pad. We have this linear lucency through the bone. This is the most common location for a fracture in the pediatric population at the elbow. Just nice to know and see because often tested on shelf exams. Moving on to neuro, we have a CT image of the head, a sagittal MRI image of the head. We have a suprasellar mass that's partially calcified. This is the suprasellar cistern here. It's bright on T2 weighted imaging. This is none other than a craniopharyngioma, the most common non-glial pediatric intracranial tumor. Look for the calcified suprasellar mass, will typically present with headache, visual disturbance, and academic decline. That's an important clue towards a diagnosis. They'll likely be asking, what's the most likely diagnosis? When you see academic decline in a suprasellar mass that's calcified, always think of craniopharyngioma. Moving on to case 23, we have a non-contrast CT image through the head. Remember that anything that's bright on a non-contrast CT is hemorrhage or blood. I want to point your attention to this area here, this convex, extraaxial, hyperdense or bright area here. This is none other than an epidural hematoma, right? Bright, lens-shaped, convex borders. Nice example of what an epidural hematoma would be. Now, this area here, which is, concave, this would be a subdural hematoma, right? Which is different, right? So this patient actually has a subdural hematoma and also an epidural hematoma. But I want to show you this epidural hematoma because this is associated with skull fractures, which is testable, and also rupture of the middle meningeal artery, right? So very testable associations for an epidural hematoma, which is convex and lens-shaped, as opposed to, crescent shape, which is seen in a subdural hematoma. And last but not least, this is a case of acute sinusitis. There's a coronal image through the head. We have opacification of, this is the left maxillary sinus. Here, this is the right maxillary sinus. It should normally be dark and black, but this gray stuff means that there's opacity in here. There is a little bit of mucosal thickening in the right maxillary sinus, but the whole left maxillary sinus is opacified. This is a nice example of what maxillary sinusitis would look like. Look for the air fluid levels that are sometimes seen. This is a nice example of what maxillary sinusitis would look like on the shelf exam. Thank you so much for your attention. Go ace your exam. Hopefully those are super high yield images for the PEDS shelf exam. Please subscribe to MedED page and support our mission. Thank you so much for your attention.